Welcome to Compassionate Conversations. The goal of our podcast is to explore topics related to serious illness. Ancora Compassionate Care exists to be a supportive presence for life's journey. We can provide care and support wherever a patient may be on their journey with a serious illness. Ancora Compassionate Care began as Hospice of Rockingham County in 1987. While our name changed in late 2023, we are still the local provider the community has always known. We'll always be there because we've always been here.
Hello everyone, welcome to this edition of Compassionate Conversations. I'm Flavel Collins and I'm Director of Marketing for Ancora Compassionate Care. And with me today is Rhonda Lucas, who is not only nurse practitioner, but she is also our Director of Serious Illness Care. So welcome, Rhonda.
Thank you. It's always great to be here.
Good. So today, let's really kind of dive into serious illness care, which is palliative care, that we refer to as serious illness care. That is the name of the program. So when people hear the word palliative care, what should come to mind, do you think?
Well, the word palliate means to control symptoms. It's in regards to symptoms, shortness of breath, pain, nausea, vomiting, that type of thing. But in this context, it's more, it can be anyone, not just someone who has a disease that is life-limiting. And those are the majority of our patients. But we have a small subset of our patients who may be on palliative care for a season, and then they come off the palliative care.
Right.
And I think that's what you wanted to focus on today.
So you mentioned limited life expectancy for some, but that's not, palliative care is not necessarily for those at end of life.
No. So anyone with a serious illness that has symptoms that are not controlled by their primary care or their specialist for their disease, like their oncologist if they have cancer, or their lung doctor, pulmonologist if they have COPD, for example, if those symptoms aren't controlled, or that specialist or the primary care doctor or provider says, we need a little bit of extra expertise in just symptom management. And it's a time, sometimes it takes time to work with medicines, with patients, and even non-pharmacological things to get someone comfortable. So they ask for our input. And so we make those visits until they're comfortable. Sometimes that's through to death. Sometimes it's just for a short period of time. It's as long as they need us.
Right.
And until they're comfortable. And that's our goal. I tell people, our goal is to make you help you be as healthy as possible, live your best life while staying out of the hospital. That's really our goal.
Right. So quality of life.
Quality. It's all about
all the
quality.
Way around. So that being said, we know that hospice care also focuses on quality of life.
That's right.
But how is palliative care different from hospice? Can say my husband has whatever, let's say Parkinson's. Can he still have whatever treatments might be available?
Sure.
And be in the palliative care program, our serious illness care program?
And that's the big difference between our patients and hospice patients. Number one is the life expectancy, because once somebody is so ill that they don't expect their prognosis to be longer than 6 months, they can be on hospice. Not everybody chooses hospice. Once in a while we'll have somebody that says, no, I don't want that. And if they don't, then they'll stay with us for as long as possible.
Right.
But there are many folks who want to continue getting treatment. They want to continue getting, whether it's therapy in Parkinson's, for example. They want to continue that physical therapy intermittently to keep them as strong and independent as possible, and to help their caregivers take care of them. Maybe it's speech, because if you've ever known anybody with Parkinson's, sometimes their speech is slurred or they have trouble swallowing, those things. So that's when another kind of therapy. But anytime they want any kind of therapy or therapeutics, like medicines or treatments, then they're on our service.
Okay, well, that makes sense.
Yeah.
That makes sense. So say I were the caregiver for someone with a serious illness. How do I know if palliative care is right for them, if that would be something beneficial for them?
Well, we have this guideline of 2 years or less, but nobody has a crystal ball.
Right.
So we don't know. So ask us to come in and do an evaluation, or to have a conversation with us over the phone. And we ask them questions on referral, like if a wife can call in that referral for her husband, or a neighbor with her permission can call it in. We can talk to that wife, for example, and ask some questions and kind of get a feel, for what's going on and what's needed. We're also there for caregiver support, which is a huge, huge thing. Caring for someone with a serious illness, especially in folks who are older, and we're seeing people live longer. So those folks like me who are in baby boomers, we're probably going to be taking care of our spouses longer than anybody has ever done before.
Right.
And in order to take care of my husband, I need to take care of me. And that's where we come into. Now, we may not come in and actually do for them. We don't have aid services associated with our program,
Right.
but we have resources that we can refer them to, and just be a listening ear on our visits, and just let them know that they're not alone. And there are caregiver support groups through our organization, through other organizations, depending on the disease. I think especially of folks who are caregiving for dementia, or Parkinson's, they don't get sick and they're gone in 2 or 3 years.
Right.
We're
That's
talking an 8 to 10 year
slow,
journey,
gradual,
and it is long and it is arduous and it can be very hard. And to let people know they're not alone, there's support, and if their loved one's not sleeping at night, well, there's a symptom that's not controlled, so it might be something we can help with. So we try to do all we can to help both the patient and the caregiver.
Sure, that's huge.
Stay well.
Yeah.
Whether it's emotionally and physically well, or there's so much to being a caregiver, and I know more than ever now.
Right.
As being one.
Yeah. Well, I've said it many times. It's the hardest job anybody will ever do.
Yes.
And to know that there are programs out there, like our serious illness care program, that yes, it's for the patient, but there's that caregiver support, and just having us, y'all, as a resource for the resources, if you will, because so often when you're in the middle of caring for someone, you don't know what's available, or you don't have time to do the research to find out what's available.
Because again, that takes time.
Exactly.
And that's time that mom may need you to help her bathe, or to, caregivers don't get enough time to do their own personal things. That's why typically they let their own health be put aside.
Sure.
And so by the time their loved one is to the point where, whether they either pass or, they're not able to take care of them by themselves anymore, a lot of times they're sick themselves because they put their own health on the back burner.
Right.
And so one of the things I try to do is explain, we know that your husband's going to be taken care of one way or the other, because you're going to make sure of it. So we're here to help make sure that you're taken care of too. And we have great resources that we find out about through our social work department, through our growth department. Right now, there's access to grant money for respite for caregivers that's been made available.
Oh, wow.
And we just found out that through our growth department, because she networks with other folks in our county who know about the resources. So we try to share those among ourselves And how wonderful, a $500, I think it's a $500 voucher for some respite hours.
Wow.
I mean, that's worth a lot more than that to a caregiver.
Sure. And how life-changing that could be for a caregiver.
And it's specifically for dementia patients, but it is available through a limited time.
That's great information. That's great information. So you were talking about having conversations and whatnot. Walk us through a little bit of what a typical, if there is such a thing, and I know there's really not. If you've seen one palliative patient, you've seen one. But what does a palliative care visit look like?
Well, the initial visit is a little bit longer. It takes about an hour, sometimes an hour and a half, but usually it's an hour and 15 minutes. And it's initiated by explaining the program in more detail. That's explained on the phone, and sometimes they will sign the consents digitally, so we don't do the actual signed consents on the form, on the first visit. But today I did one this morning, and we had to do that, and that was fine. I explained the whole program, how often I'm going to be seeing them and where, and then I go to the physical, and I review their history with them, their medicines, their allergies. Then I actually do a head-to-toe physical on them in the home. Vital signs, listen to their heart and lungs, their belly, looking to see if they have any swelling, asking about symptoms as I go from head to toe. Headache, dizziness, chest pain, shortness of breath, all that. And then after the physical, we talk about depression. We do a depression screening. There also is a caregiver screening tool we're going to be using in the near future to help us and guide us in caregivers, because they're not going to ask for help.
No,
so you
not
have
typically.
You have to kind of have the ear for the little ideas things that they'll say that you know that they're under stress or distress, and then. But with this tool, we're going to be able to follow that more closely, I think, in them making headway, or same way with any symptom. And then we talk about what is that person, if they're still alert and oriented, like my person today, asking her, what do you want done in this case scenario, If they don't already have a living will and any advanced care planning documents done, we talk about all those and all the options.
Okay.
CPR, no CPR, being put on a machine or not, going to the hospital or not. So we get a feel, and unfortunately there are those folks who's never even thought about it, and they've not had the discussion with their loved ones. And so I encourage that. I said, you know what, especially this time of year, I'll say, Thanksgiving's coming up. You've got your family, hopefully within the next few months, your family's going to be around. Ask them and tell them and get input from them if you want it. And so then we go from there to a plan. What are we going to do between now and the next visit, which is usually anywhere from 4 to 8 weeks. Usually it's around 6 weeks. And in between our visits, every 6 weeks, our nurse calls and make sure that they're okay. There's not been any changes in medicine. They've not been in the hospital. So that's what the visit looks like. It kind of goes from getting permission to reviewing history to what is the actual here now physical exam, any complaints, and then a plan going here forward. And so we kind of make goals, and we'll say, okay, at our next visit, we're going to talk about such and such, you know. Yep. And until then, would you do some homework or be thinking about this or that?
Right.
Go over their medicines.
Well, you were talking about advanced care planning and talking about goals. I think it's human nature to think, well, we've got time to talk about that. And then something happens and you're in the middle of a crisis and no conversations have been had, no plans have been made. So to help walk folks through some goals of care conversations and some advanced care planning is huge. I mean, that's an amazing benefit of the program. outside of everything else that you all can do.
Well, we've said it on here before, but it still stands true. We get referrals from our especially our primary care offices in the area and hospitals. They don't have time to talk about those things. Their time with the patient's very limited, and they don't have time to talk with their folks about advanced care planning, because it's like a 30 to 45 minute conversation.
Well, I was going to say, and not only is it not a 10 or 15 minute conversation, but it could be that after the first conversation, really all that you've been able to do is plant some seeds and
That's
give
correct.
them things to
It's the
think
follow-up.
about. Yes.
Yes.
So yeah, it's not a one and done kind of conversation.
No, and if you
a lot
push
of the time.
folks, they don't even want, So I tell them, I says, we don't have to make any decisions. You don't have to make any decisions right now. But I do a lot of education if they don't know. Now, some people I go in and they know exactly what they want. But other folks are like I was a couple of years ago. I was facing what could have been my husband being in a coma for the rest of his life. I didn't know if he was going to wake up or not. Nobody did. And so I'm laying in the bed thinking about, what's my plan B? I talk to people about it all the time. And Robert and I never really talked about it.
Right.
So I think that even whether you're 40s, 50s, 60s, even 20s, because something can happen to someone. What am I going to do if? And so I call it the plan B.
Yep.
If I can no longer take care of you in home, what is the plan?
Right. Right. Good conversations to have. Talking about the visit, where does the visit happen?
Wherever the patient is, it can be in the home if they have problems with transportation or have to use medical transportation or are bedbound or homebound, then we go to them. If they can come in, if they go to other doctors' visits, and they can come to us in our clinic in Wentworth, we do that. We have it's only a year old now, in our new East Campus building, right there in the heart of things in Wentworth. Right. And it's a great clinic space. And I tell people all the time, I'm so proud of it because there's no waiting.
Right.
Check.
I was going to say, check.
You don't get that in other doctors or in other clinics. There's no other patients waiting in there for you to get sick or germs from. The nurse meets you right there, takes you right to your room. You're in a room by yourself. The clinician, either Catherine or I, come in there within 5 minutes. And they're roomed, their vital signs are taken. She brings us their vital signs and whatever complaints are coming in with that day. We go right to the room, and then we have 45 minutes set up for them.
Wow.
And that's unheard of.
Yeah.
Except in palliative care programs. But every serious illness palliative care program is different.
Right.
Going to the national seminar 2 weeks ago, I met folks like Duke's program. They have a great program, but it's only in the hospital and in a clinic setting. Mm-hmm. They don't see folks at home. Mm-hmm. And then I saw people I met a girl from Montana who they see people in the home, but they may have 45 minutes between patients. So it's just, but we all do the same thing.
Right.
We all palliate symptoms.
Yep.
And help people live their best life.
Well, and I think, the fact that, and again, you're right, all programs are similar but different. But the fact that we do see patients in their own home, if
makes
need
us
be,
stand out in this area.
It does, and it goes back to our mission of being a supportive presence for life's journey and meeting the patient where they are.
And having our 2 other service lines. If someone in our service gets to the point where they need hospice, it is a seamless transition. Mm-hmm. Usually next day, unless the family wants it put off for a few days. Yeah. Seamless transition. Let's say the caregiver is in distress and they need someone to talk to. We have the counseling center.
Right.
If they need resources that Catherine and I don't know about, we have social workers that we can get that information from, or to help with the health care power attorney and advance directives. I mean, we have such a rich program here that there's not a lot that can't be done within our own organization.
Right.
We can guarantee, that's a strong word, but I tell people, I says, if you trust me, you can trust this person in this program or this person in this program.
Right.
Because we all are of the same work environment.
Yeah. We're all focused
and
on
our
that
culture here is
one
the
mission.
same.
Yeah.
That's right.
Yeah.
And it's all patient driven.
Yeah. You were talking about visits, which reminded me, if someone is interested in serious illness care, do they need to reach out to their provider for a referral? Can they pick up the phone and refer themselves or their loved one? How does that work?
Well, either way is okay, but if you reach out to us directly, then we will reach out to your primary care physician and let them know that you have called in with a need and or have we been out there or we've not been out there. We coordinate. We don't take the place of their primary care doctor or provider, because we don't want to step on. We want to stay in our lane and have professional courtesy, and we all want to work together we all have the same goal, and that's for the patient to be the best that they can be physically and emotionally. So we try to work together. We communicate a lot with other providers, whether it's specialist or primary care, and but
So you're helping
I would say
coordinate
probably
care.
the quickest way is to call us directly.
Yep.
Because with one phone call, you're going to find out if that person qualifies and if we're going to be able to provide what you need. Because sometimes people need help with aid service, bailiff, they're not home. So just a conversation, I can say, well, we can't offer that, but I can tell you who can, or how and what your options are depending on your income. So it's all, a lot of times I feel as much like a facilitator as I do a provider, but that's okay because there's not that many places to get that except your insurance company. And if you have an insurance company that is that high touch with you, then you have a navigator or a case manager or whatever they call them, then that's great. But a lot of times they may not even be here in this area. So we know what's available, locally.
Right.
But it's a great privilege to be able to help somebody kind of navigate or maneuver.
Absolutely. You mentioned insurance company, which reminded me, who pays for palliative care? Is it covered by insurance, Medicare, Medicaid? What should families know about?
We have not had any denials, even VA. We've not had anybody. We check insurance first so that we can let the patient know if it's covered, and if so, if they have a copay or co-insurance. Because some people just have Medicare and they don't have a supplement. Some people have Medicaid only. It depends on their age and everything. And so we've not had that a problem. We are starting something new coming up that we're going to be looking more at trying to retrieve our copays. That's not a bad thing. We're all used to that. And but there are a lot of folks that don't have any copay. So and we come out to you. Or can, if you qualify for home visits. So, but VA, Medicare, Medicaid, and private insurances all do.
That's excellent.
Now, right now, we're on a hiatus after yesterday about our televisits, because normally we would do televisits in between of in person. But right now, until Congress smooths that over and gets the budget done, we're not doing telehealth right now. We're hoping that'll soon be rectified.
Yeah, we'll keep our fingers crossed that that's back in place very soon.
I think it will be.
So what do you wish that every patient and caregiver knew about serious illness care?
that we don't come in and tell you how to live. We're there to give you advice, but then you don't have to, you are the director or the captain of your own ship. Mm-hmm. And we want people to be as autonomous as possible. Mm-hmm. It's a lot of times people have lost so much control if they're really sick. Mm-hmm. And they don't feel like they have any control over any decision making anymore. And that's not true. And we try to empower them to direct their own paths. If they want everything done, no matter what it's going to cost, physically or mentally, we're with you along that path. If you decide you just want comfort care, you're in your 90s, you've had a good life, you just want to stay at home and go in your recliner on your own bed, we're with you on that journey too.
Nothing wrong with that plan.
No. So it's wherever, and if you're anywhere in between, we meet you there.
Right.
We communicate with the hospitals. We know now we're part of a system or platform, if you will, of local hospitals that we get a notification every time one of our patients goes into the hospital or goes to urgent care or goes to the emergency room, admitted, home health comes in or out. So we stay on top of things a whole lot better than we did a year ago. It's called Bamboo Health. This is great. It's been a great asset for us to keep up with our folks.
Sure.
Because if you've got someone sick and going in and out of the hospital all the time, you don't have time to call and notify somebody every time.
Right. That's not high on your priority list. Right.
So now so we can talk to those folks at the hospital or wherever you are, or whoever's giving service to you, and say, hey, let's coordinate. I'm seeing them and you're seeing them. So let's talk for a few minutes. And people have been in our area have been so open to that. And in the other realms, like the hospitals and clinics. And I'm finding that the more we communicate, well, that's always going to be better for the patient.
Sure.
This fragmented care of this one doing that, and nobody talking is just, it's not good.
Yeah. Well, to me, if I were a caregiver or a patient, knowing that I had an advocate and a liaison on my side and in my corner would be tremendous reassurance.
Yeah, sometimes, it's hard not being that strong advocate because, people go, well, and I'm like, you don't understand. Let's say a drug. Let's say I want to order them something for pain or anxiety. It's a symptom. We're trying to control it. So, and the insurance company puts up prior authorization thing, and I have to fill out why they need this medicine and why something else hasn't worked or whatever. And I have made calls and said, you know what, you don't understand. This person's quality of life depends on this medicine. They've tried this and this and this, it's not working. And they'll say, okay, we'll get you an answer, and within 10 minutes I get the faxes. I'm not saying it's not me, but you have to make the case for the people. And people don't want to do that always for folks. If they have this many patients, they've got that many prior authorizations to do, it's not done very quickly.
Right. Wow. What support?
And I feel like I've done something that, I feel like I've done something every day. It's very fulfilling work. But when I have advocated for somebody and it went through, I got that medicine approved, for example, like yesterday. I was like, yes. And to call that patient and say, hey, I got it approved. You can go pick it up from the pharmacy. Let me know in 2 days how it's working for you, or 3 days. So
yeah, that's amazing. If only we all had some sort of support, an advocate in our corner all the time.
This is a person who has cancer or had cancer. The cancer has been eradicated. The treatment has caused symptoms that will be with her the rest of her life. And so just something for those symptoms, because it seems that this one says, that's not my area, and somebody else says, this isn't my area. And I said, well, it is in my area.
Right.
So we took care of it. Yeah. Hopefully we took care of it yesterday. Yeah. We'll see how it works.
Yeah, we've got this.
Yes.
Yeah. And you mentioned the cancer patient. I think a lot of people think about palliative care for something long-term, and you mentioned that, some of our patients, it is just for a season, in the case of our cancer patients.
That's right.
That, it may just be while they're being treated, and then once things are in remission and things are better, and they don't need us anymore.
That's right.
So it could be.
And sometimes it's just because they've learned how to control or how to monitor themselves and take their medicines correctly so that their disease is under control. And that's a win every time.
Every time.
Yeah.
Every time. So, well, I feel like we've kind of touched on a lot of things, and I appreciate you being here with me today, and hopefully, we've shed a little more light on serious illness care, palliative care, whatever the name of the program might be, so that a little less hesitancy maybe to reach out about this program.
Because I think the public has heard the word palliative care for years now, but it was always associated with hospice. And so they think, oh no, I'm not ready for hospice,
Right.
And I'm like, but I'm not with hospice.
Right.
I work for a company that has a division of hospice, but that's not what I do.
Right.
And then they seem to like, okay.
Yeah. In my mind, for years, I always have to tell myself that hospice is always palliative in nature, but palliative care isn't always hospice.
That's right.
So that's what we hope folks will remember.
And we both said this thing about when you've seen a program, you've seen a program. I actually, at that conference, they actually had a concurrent session that was named that. When you've seen a palliative care program, you've seen one, because we all recognize that it's community need based, and this is what works for our community.
Right.
And when people find out we do it here, they're like, "Oh wow, that's great!" And I'm like, "Yeah, it really is." And to be in, I came in 1 year after it was initiated, and now to be the director of it, it's a privilege.
Yeah, it's really grown, and it's exciting to see where
and
we go.
We've got
from here.
goals for the next year or so that, this is going to be really exciting to help more folks.
All right. Well, thanks again. Thank you for joining us for this edition of Compassionate Conversations. If you have questions about our serious illness care program, please reach out by calling us at 336-427-9022, or you can visit our website at www.ancoracc.org.